Okay, thanks, Stephen. So, as you know, that ESCMID is a very huge clinical microbiology and infectious disease update of Europe. So, all of us are there is like running health skelter, chasing after every lecture. So, we cannot cover all, but the most important topics that I find interesting to share. So, bear with me. I hope I can finish within 15 minutes. Okay. So I'm going to talk about gram-negative bacilli or difficult to treat GNR, pertaining to what is the newer agents that is in the pipeline or already in the market in Europe. So the first question is I always ponder upon is, a lot of clinicians or juniors, they ask us, is carrier of CRE and ESBL a marker for us to start empirical treatment for those patients who presented with sepsis? So the answer is yes, as you can see that a lot of this is a case history where the patient is admitted in a high resistant MDR-DDR carrier hospitalization in an area where he flew back from that area to the Europe country where there is low incidence of MDR-DDR. So whether we should start empirically to treat these patients, this patient is actually collapse upon some procedures, and then they intubate, and that patient had HAP. So the answer is yes, because from the systemic review, it is this systemic review shows that the risk of infection of colonized patients, particularly 26 studies touch on GNB, mostly high and middle income countries, then the risk of infections concluded is if it's an ESBL carrier, they would have about 8% to 10% of risk to get true infections of HAI, and the CRE carrier is up to 19%. So the next topic that I'm going to interested to talk about is this carrier with infection risk. So this is increased relative abundance of Klebsiella pneumoniae carbapenemase producing KP within the gut microbiota is associated with the risk of bloodstream infection in a long-term acute care hospital. So what did they do is they weekly do rectal swabs collected in patients in the long-term healthcare area, and the sample positive for KPC, KPN, then had analysis of the GI microbiome to determine the relative abundance of this. And then they follow up and they look at it, and they say that those patients are actually at risk to have BSI if they have a carrier also as well. So the next topic is about PCR based. Now we have a lot of molecular based PCR testing like BCID from the BioFire and the pneumonia panel, So they were saying that be careful with interpreting this PCR, MPCR, because some of the microorganisms that are not in the panels are not shown in the panels. Doesn't mean that the patient doesn't have sepsis. For example, those bacteria like Burkholderia shipacia, Burkholderia pseudomyeli, Ralstonia, Sphingomonas, Elizabeth Kinga, these are all healthcare associated infections bacteria, which is not going to be picked up by our molecular panel, especially BCID2. And then others like Aeromonas, Vibrio, and Brucella also not being tested also as well. There is no target panel there. So what about the mechanism of gene also? Not all the resistant gene is detected. They only detect MAC-A gene for MRSA, CTXM for ESBL, OXA48 and NDM in the panels for CP-CRE. So some of the resistant mechanisms are not available. It doesn't mean that the test has no detected gene. Doesn't mean that the patient does not have resistant. So for example, they give is gram stain tracheoaspirate is Coccobacilli. So it detect for MPCR is ACB, but there's no OXA48. Okay, so do you not treat MDR ACB in this scenario? If the patient is the same patient, after collapse, intubated, and then had a HAP, these come out, and whether you are bold enough not to cover as carbapenem resistant Acinetobacter or not. So the answer is you should not be rely on MPCR because not all the resistant gene is detected in the MPCR. So another one is antibiogram interpreting in gram-negative. So they gave example that, some of the very weird organisms that have been detected, then you can use Enterobacterialis if it's the Enterobacterials. Then you can use antibiogram to test the antibiotic panels for Enterobacterials. For Pseudomonas, you can use Pseudomonas. But for those organism gram-negative that has no known panel, like Elizabeth Kingia, there's no sets of antimicrobial agent to be tested. So what did you do? So when there's no clinical breakpoint, so you have to go and look at the literature of what they have used to treat. So those literature say that Ribos, Cipro, Bactrim, minocycline has been reported to treat Elizabeth Kingia. So the next is you should not use this diffusion method because it's not reliable. So you must use MIC. So this MIC sometimes is from Vitek or sometimes it's you need to do MIC test. And after you get MIC test, because there's no clinical breakpoints, so you are only go against with gram-negative organisms. So the report of your susceptibility report, you can only do like this. Levofloxacin agent may be considered for therapy. Cipro is resistant. Bactrim agent can be considered for therapy. This is the right way of reporting if there's no clinical breakpoint. Okay. So another issue is from phenotypically, this is microbiology. If this is an E. coli isolates, and you can see that ceftazidime is resistant. So when you have a ceftazidime is resistant, you always have in mind is ESBL. However, you can see that cefotaxime and CRO is ceftriaxone is zone of inhibition is so good. So whether this is ESBL or not. So it's very interesting. So the answer is yes, it's a variance of ESBL because most of the time ESBL is very frequently is CTXM, but we have other variants like TAM10, TAM13, SHV2 and SHV5. So in this scenario, it is actually an ESBL, even though cefotaxime and ceftriaxone is remain sensitive. So the answer that somebody is asking whether we should suppress the ceftriaxone and cefotaxime to be resistant because you think it is a ESBL. The answer is no. You should report it as it is because it may be useful still because it's a variance of ESBL. So you should report as cefotaxime and ceftriaxone that is still sensitive, but ceftazidime is resistant. So this is another scenario to tell you that CTXM is in the biofire panel, but not TAM and SHV. So if you do not detect CTXM in an E. coli, which is detected by MPCR, doesn't mean that it is not the ESBL E. coli. So you still have to wait for phenotypic culture to come out and say that whether this patient has ESBL strain or not. So for Pseudomonas, again, another one, as you can see that if you have a cephidrocol that is resistant or Astronam that is sensitive and cephidrocol that is actually halfway. So you got high resistance of ceftazidime, CT is resistant. And then you can see that, oh, maybe I should use my laser pointer. Oh, sorry. How to make it smaller? Where's my laser? Can you see my cursor? If you CT, ceftazidime and tazobactam, and imipenem and relebactam is resistant, and you have an Astronam that is a bit sensitive, this is already a proven carbapinamases production. And if it's a cephidrocol shows partial resistant, it is likely to be NDM. As you can see, the cephidrocol for NDM is actually resistant. So when your cephidrocol MIC is more than 4, most likely you are dealing with NDM producers. So another topic that I'm going to touch on is antimicrobial puzzle. You want to solve this, whether the newer beta-lactam, beta-lactamase combinations is good. This is a good slide. I'm going to share these slides for you all, but I'm not going to go through how our thinking process. I think most of our ID physicians had trained to think about how to deal with sepsis, whether you need to cover MDRO or not. You are looking at geographical, you are looking at clinical history of colonizations, you are looking at antibiotic exposure, and also you are looking at the clinical scenario, whether they are in septic shock or whether they are immunocompromised, to make your decision whether you need to start empirically to cover MDRO. So this is another slide, but I'm not going to go deep. I'm going to go straight to one of the question, whether ceftazidime avibactam resistant. So you will know that ceftazidime avibactam is our newer kids on the block, but not newer kids on the block in Europe. They have used it many, many years ahead of us. So there are actually reporting about ceftazidime avibactam resistant enterobacteriaceae, especially the risk of developing in vivo. That means you are treating the patients who are sensitive, later become resistant, particularly in those patients who are renal replacement therapy, delayed or absence of source control, septic thrombi is there, or the patients with pneumonia. So they realize that for this ceftazidime avibactam resistance, it is actually the resistance is actually happen in mutations in the beta-lactamase structural genes, particularly those affecting avibactam binding sites, as in blood KPC 31 and 30, and in the omega loop. So this is a very, very real scenario, and it has been reported and is already spreading in the Europe country. So how do you want to solve this issue? So another newer beta-lactamase inhibitor like imidazobactam, they couple with cefepime. So they actually, these are the antibiotic that particularly going to treat carbapenem-sparing agents for ESBL, MC high producer, especially high inoculum effect, and also possibly to treat Cefta-Avi resistant KPC. Okay, this is the resistant KPC that I'm talking about, the omega loop blood KPC 31 and 30 in the omega loop. Okay, so and also it can treat OSA 48 also as well. So this is a newer agent called cefepime imidazobactam, but mind you that it is not so good for MBL still, but it is actually can be treated for patients who are Cefta-Avi resistant KPC, which is tested sensitive with cefepime imidazobactam. So the potential useful effect is a sparing agent for ESBL, and also it can be used for particularly Cefta-Avi resistant KPC strain, which shows sensitivity. So what is the antibiotic strategy to combat AMR? So this is an interesting topic that presented by Patterson. He brought up the issue that we should look back now. What are those antibiotics that can promote colonization for gram-negative CRE or CPE? Okay, so he brought back the studies that in earlier 2000 to look at people who have VRE high, and then they look at what are those risk factor where the VRE is high. So they realized that the patients who are on anaerobe coverage, antibiotics that has anaerobe coverage, will have increased risk for VRE colonization in the GI microbiota. Okay, so what are those anti-anaerobic antibiotics that are piperacillin? Piperacillin itself is an anaerobic. So when you cover with piperacillin tazobactam or piperacillin itself, it has anti-anaerobic. And then ampicillin sulbactam, amoxicillin clavulanate, cefoxitin, imipenem, celestine, meropenem, metronidazole, clindamycin. And a lot of people are asking him that ceftriaxone. Then in a special scenario where ceftriaxone is concentrated in the gallbladder, it has some anti-anaerobic effect. Those who are purely aerobic coverage without anaerobic, like cipralevo, cloxacillin, cefalexin, cefepime, they are all stable, more stable, and not selecting VRE. So currently, they look at gram-negative. All right, this is the newer paper. This is a very interesting. It is published in the Nature Communication. What they do is they collect feces from 5 healthy human donors, and all these 5 feces they inject piptazole onto the feces, and one also with the water. And then they calculate where the CRE, they inject CRE strains inside and see whether the stool CRE can survive or not in the environment of water or piptazole. So for the piptazole one, you can see that it overgrow of a CPE, CRE strain in the stool, but not in the water. So currently, because the theory is because of the nutrients that is elevated by the piptazole treatment decreased with carbapenem-resistant E. coli colonization in the feces from a mouse model. So this is a hypothesis, is antibiotic decrease gut commensals, especially bacteroides, particularly in anaerobics, promoting carbapenem-resistant enterobacteria since they enrich the certain nutrients, and the CRE use these nutrients as a carbon and nitrogen resources. So should we now look back that transit from carbapenem sparing to anti-anaerobic sparing? So don't use anaerobic coverage where that is not needed. That is the possibility hypothesis. So that's why I was thinking that the patients on piptazole, on augmentin, you know, in the ICU, the next week, initially is the CRE negative, but the next week itself, the CRE in the stool, in the rectal swab become positive. So that's why our intensivists always ask me, why augmentin? Why unicin also can cause that? So I think that is probably the answer, okay? So now about the CRE. So it is a summary slide of newer antibiotic in the already, almost or some of it already launched in the market. So we know about Cefta-IV. Then we talk about this meropenem verbobactam. So meropenem verbobactam is not going to deal with our NDM, but it can deal with KPC or an MC producer. But our Aztreonam avibactam, that is already launched in the Europe, it is actually to cover NDM, your KPC, your VIM, your MC, and your OXA48, all right? So, but the sulbactam and durlobactam is mainly designed for carbapenem resistance, Acinetobacter baumannii. So iravacycline also is mainly to be used in also CRAB, okay? And then cefiderocol, even though you can see that cefiderocol has green and yellow, but be careful because of the inoculum effect. Cefiderocol hasn't been shown to be good in severe infection. So this is Emblavio or the Aztreonam avibactam. Currently, we are using Cefta-IV plus avibactam together with the Y connector or T connector to go to give to the patient. But this is actually already 2-in-1 and fixed together. And the trial data to show that it has non-inferior or better in terms of MBL strains, but mind you, these are only minimal sample, only 12 patients is assembled, 7 in revisit. So they are used to treat CIAI, HABP, and VABP. Okay. And then what about cefiderocol? As you all know that and understood that cefiderocol is actually a siderophore cephalosporins, where they actually being used iron, and then the bacteria will absorb iron for themselves, and then hence they will actively transport in the periplasmic space, and then the effect on OXA, KPC, VIM is with MIC90 is good, but then for NDM it's not good. So if you have NDM will be there if the MIC is more than 4, so you cannot use cefiderocol already. And cefiderocol, incredible CR trials had shown higher mortality versus for treatment for Acinetobacter or more than Klebsiella. But in a game changer, it shows non-inferior to the comparator for bloodstream infections. Okay, so this is the newer antibiotic BLI in the pipeline. So I just found out that they are grouped into penicillinic acid sulfones, which is what we are seeing, the first generation where we are always see like sulbactam, tazobactam, and enitazobactam. And then we have a DBOs, which is our abibactam, zidibactam, and durlobactam. And now we are looking at boronic acids, where this is going to treat or solve our problem, more of our problem of NDM, like verbobactam, tanibobactam, and zirobobactam. Okay. So there are many in the horizon, like cefepime tanibobactam, which is going to be good for our NDM, cefepime zidibactam, imipenem silacin, or flunobactam. These are all mainly to treat, most of it is KPC. Some of it has effect on NDM. However, there is one final thing that I want to highlight is the PBP3, where this is the area where most of our newer antibiotic or beta-lactamase inhibitor will attach them onto PBP3, and the mutation can occur in the PBP3 with PBP3 insert. When this happens, all these beta-lactamase will lose its efficacy. So what to treat? We go back to polymyxin or even tigecycline or eravacycline most of the time. And until now, we do not have a good antibiotic if this mutation occur with PBP3. Okay, so this is the summary, a glance through. If you are interested in looking at our MBL, the only thing that we can look for is cefepime taniborbactam and also Aztreonam avibactam here. Okay, so taniborbactam is one we are looking at. All right. Okay, that's my last slide. Thank you.
Thank you, Dr. Chow. Thank you for the enlightening presentations. Any questions from the participants? If you have questions, just unmute yourself and then introduce yourself and then ask a question. I think we know each other, so we don't have to be so formal. Anyone? Dr. Chow, just now you mentioned about the anaerobic coverage, anaerobic activity of antibiotics that can actually promote CRE. Right. So, are we suggesting that, if you want to avoid anaerobic coverage, unnecessary anaerobic coverage, that means in terms of de-escalation strategy, let's say, well, I want to de-escalate meropenem to a narrow spectrum antibiotics, I should go for cephalosporin rather than a beta-lactamase inhibitors?
Yes, it looks like what we are trying to say is, like CAP, we use augmentin, may not be good options.
So we should
Maybe
use
we have to go to
ceftriaxone.
cefuroxime rather than,
Ceftriaxone or ceftriaxone. Yeah, because when I was under training in Melbourne, I think they actually use more of ceftriaxone compared to BI.
BLI.
Yeah. So yeah.
Cefuroxime, but ceftriaxone has a little bit in high dose, it can have anaerobic effect. Remember that slide?
Correct.
Yeah.
What about cefazolin?
Yeah, no anaerobic.
No, right? Yeah. So I'm just
Cefuroxime
thinking.
also none.
So I'm just thinking, if let's say we are treating a Klebsiella pneumonia, bacteremia, and
we can use cefuroxime lah.
we use ceftriaxone, right?
Yeah. Okay, this is Lily here. Can I just ask? Yeah, I can't remember when I was in Australia. I think they do not have augmentin formulation, but that was very long ago. But the way I look at it, probably we should not move away from augmentin. Probably we have to re-stratify those patients that we anticipate longer stay. They are more ill, whereby the risk of colonized by CRE is higher. Maybe we should try to avoid those anaerobic coverage. But those patients short stay, for example, CAP, probably there's still a room to use augmentin because we anticipate that this group of patient will go home very fast, so they won't get CRE. Even they get it, we don't want to know because they'll be going home.
So, but the message is do not try not to cover anaerobic. So, if you do not require.
Maybe what is more important here is comparing piptazole and cefepime. Anyway, my center, because the piptazole has there's a lot of resistance. Our E. coli, Klebsiella, higher resistance to piptazole. Therefore, we are moving towards cefepime. So maybe that we can see our data comparing now and previous when we use the piptazole, whether is there a difference in terms of CRE incidence.
So I do not purposely go and look for it, but it has multi-factor in Penang. In Penang, we stopped using piptazole way, maybe in 2020, we realized we are seeing more resistance. For sensitive Klebsiella pneumo, only 50% sensitive to piptazole. So we actually had a letter come out, and then we have moved to cefepime since 2020. And I do not know whether it's infection control that is good, or because of this movement, our CRE carrier rectal swab positivity rate is coming down, our CRE cases are coming down, our bloodstream infection CRE does improve. I do not know, but I cannot say for sure. It may be because of infection control that is good, or cleaning that is good, somehow or other.
Yeah. So I guess if we are mainly targeting Pseudomonas, we probably can try to avoid using diazoxin from now, right? We probably go for cefepime or
Are
ceftazidime.
you all seeing pip-tazo resistance rate going up for sensitive gram-negative? Our side, yes,
My
still
side,
not recover.
not really, I think. Yeah.
Mm.
Another concern I have is that because nowadays we are trying to, when we talk about AMS, we try to promote this aware classification by WHO. And then we know that Augmentin, unasins, this beta-lactamase inhibitors, beta-lactamase inhibitors combinations are classified as the excess group, which we want to promote usage. Now we're saying that, you should not use this group. Try to use those, in terms of empirical therapy.
I
I'm
think
not talking
like what
about.
Lily said, short use is
Mm.
okay, but not those.
Yeah.
Yeah.
Mas here.
Yeah. Hi, Dr. Mas.
Yeah, just a comment is just that I agree with Lily that there is still a role for using Augmentin in Klebsiella, especially in uncomplicated urine infection, because although that there is some resistance, but the concentration of the Augmentin in the urinary system is actually higher than MIC, you see. So I think that there's still a role in uncomplicated UTI
Okay.
for
Yeah.
Klebsiella.
I guess uncomplicated infection, short course should be okay. But if you're dealing with like abscess, osteomyelitis, we probably have to think hard, which one to choose for. If you go for six weeks kind of treatment, you probably have to decide between Augmentin and also cefroxime for Klebsiella, for example, or even E. coli.
Marcia again, I'm just wondering whether is there any role of using the Augmentin higher than the normal dose that we use, which is actually 1.2, like we look at milioidosis, we use and also intra-abdominal infections where we actually use QID and thinking about Augmentin about like for example 2 taps TDS if you want to give oral, whether there's actually an impact or not. Kind of interesting to figure out, like abscess, not so complicated, just thinking out loud.
Yeah. But my experience with patients with high dose Augmentin is that sometimes they cannot tolerate, and also compliance issue as well.
They actually had bad diarrhea.
Yeah, bad diarrhea, sometimes nausea, a lot of problems. All right. Any other questions before we move to the second speaker? Hi, Chua.
Oh yeah, that's right. Just clarify with currently in Australia. Maybe I can share a bit on my Augmentin and stuff. The relevant question, because I think based in my hospital we have like Augmentin is like orange antibiotic. So indication mainly is just for intra-abdominal sepsis, infected bikes, and also aspiration or what we call as lung abscesses. But mainly for pneumonia, if it's the mild one, we normally go for amoxicillin, or sometimes in moderate and patient is very well and they are pretty sure it's a community onset pneumonia, they go for benzyl penicillin. But if the more severe one, then they choose ceftriaxone, like what previously mentioned. And if in regards to the dose for Augmentin, like what Dr. Mas mentioned, they actually tend to go much higher dose. Like for intra-abdominal sepsis, they could go IV 2.2 gram TDS. So for intra-abdominal infection, they actually go as high as 2.2 gram TDS. And even for oral, they got the Dofort, and sometimes they add like amoxicillin sandwich, extra 1 gram on top of the Augmentin Dofort to increase the amoxicillin without increasing the clavulanic acid that caused the side effects. So just some of the experience I had sharing some of the experience I had when my time here.
Good.
But I guess in Aussie, their main organism for CAP, I think more than 90 or 95% of them are due to strep. So they can afford to use penicillin. Our data in the Asia region, I think we have a significant proportions of gram-neg like Klebsiella, especially severe pneumonia. A lot of Klebsiella as well. So we can't afford to use penicillin. At least we have to use Augmentin or
cefroxime. I think in Australia for severe one they will use that, right?
Yeah.
Ceftriaxone.
So in Aussie, they mainly cover for anaerobes now, right? They use Augmentin, unasyn to cover.
Yeah, if they like GI and then they have risk of anaerobes like abscess, lung abscess or aspiration, then definitely Augmentin. Yeah.
So
but if not, they try to do as narrow as possible. Yeah, correct.
Okay. Okay, we move on. Next is either Dr. Low or Dr. Alif. Which one of you want to go first?
I got a question, Stephen. Sorry. Go on here.
Go on. Go ahead.
Just come back to what our routine practice lah. Let's say that this particular isolate we got is a Klebsiella causing liver abscess, and then in the past we tend to use a lot of beta-lactamase inhibitor like BRBI, but with the concern that sometimes we use long durations of the cephalosporin, we may drive ESBL lah. So I'm just thinking lah. So either one of them is actually causing harm to the patients. You use a long duration of the cephalosporin, you may drive ESBL. But you use a BLBLI, then it will drive the CRE. So I think both antibiotic also has their downside as well, isn't it?
You ask patient, let patient choose that.
True.
I think the gist is at short durations. Don't extend the prolonged antibiotic when it's not needed.
Yeah.
Okay. Thank you.
Maybe let me go first because I need to run away and do a few other things before people start calling me.
All right.
Okay, let me share my slides. So can everyone view my slides?
Yes, Dr. Low.
Okay, so don't worry about my presentations. I do not have many slides, so this will be a lighter version as compared to Dr. Chow's presentations. So this is a topic on infective endocarditis, some topic that very, very often we see during our ID consults. Okay, so all of us are very familiar with the modified Dukes criteria that was introduced in 2000. In between, there was a little bit of updates. But when it comes to years 2023, I do not know whether this is a good year or some other reason. So both the Dukes International Society for Cardiovascular Infectious Disease that is based in US and as well as the European Heart Society, they decided to publish the updated guideline for infective endocarditis on the same year. So what are the differences, recommendations by the two society? So I am not going to tell you, okay, because you can just put the two paper into your AI or ChatGPT, they're going to summarize for you, okay? So you have to do a little bit of your own homework. So what's important here, the red versus the blue. So the Ronaldo versus the Messi. Yeah. So what's the difference? Why they are competing against each other, publishing the same topic of guideline in the same year. So essentially, the definitive diagnosis of infective endocarditis, they are divided into three main categories: the clinical criteria, the imaging, and microbiology evidence. So the clinical criteria I'm not going through because both society has got the different criteria that constitute the major and minor criteria. So for the new guideline, they emphasize a lot on the use or the role of imaging. So this is the imaging based on the echocardiography, whether TTE, transthoracic or transesophageal. And obviously for the TOE is more sensitive as compared to transthoracic and more so for prosthetic valve. Okay, if you use a transthoracic, the sensitivity is about 20 to 40%. So, but if we, let's say, using a TOE that operated by a senior person, the sensitivity increases to 75 and to 90. So it's just telling you that in a patient with a prosthetic valve, if let's say transthoracic shows no vegetation, you should not just believe that there is no, i.e. if let's say clinical presentation suspicious of infective endocarditis. So when to consider TOE, this is important because sometimes we have to negotiate with our cardiologist or request for TOE after the transthoracic echogram was done. So when TE is negative, yet clinically we think it's still highly suspicious of infective endocarditis, or in patient with prosthetic valve of a cardiac implantable electronic device, or to assess the complications of the IE, in particular, the patient just has undergone a surgical procedure. Okay, when the vegetation is present. So I think in this scenario, DOE is far better as compared to transthoracic. Now, Cardiac CT. So cardiac CT is less sensitive, okay, comparing to echo in the detection of vegetation, 64 versus 94%. But however, cardiac CT does have a role in infective endocarditis. For example, in situations whereby there's a lot of calcifications that may obscure the view of the valvular lesions if you do an echo. In this regards, cardiac probably is more sensitive. And CCT also has a better sensitivity in order to diagnose the pseudoaneurysm and valvular abscess, valvular perforations, or paravalvular leakage, meaning CT cardiac is more to assess the complications associated with the valvular infections or the post-surgery. So for PET-CT, okay, so PET-CT compared with the TTE and DOE combination of cardiac CT, obviously is highly sensitive, 73 to 100%, and high specificity. And this is very useful if patients just undergone the TAVI, okay, whereby they have the aortic valve implanted or replacement. And in this scenario, the leaflet will mimic as vegetation. So if we do an echo, it's very difficult to differentiate whether this is a vegetation or the leaflet post-TAVI. So in this scenario, the most sensitive imaging to diagnose or to differentiate vegetation is still PET scan. So, however, PET scan is not the gold standard to diagnose the infected endocarditis, because there are some situations that may give rise to the false positive result. For example, the artifacts or sterile inflammations or atherosclerotic plaques, necrosis, thrombi, and etc. Likewise, it may also give rise to the false negative result. For example, small vegetations, okay, attenuation over correction, even steroid therapy, and prolonged antibiotic therapy. So as a whole, there's no one tool that can help us to diagnose infective endocarditis. We need a combination of clinical criteria, imaging, and of course, microbiological results. So CIED is an implanted electrical device. So in these situations, okay, echo has got very low sensitivity because of the foreign body there. And you can't do PET scan if patient just have undergone the procedure within 6 weeks because it will give rise to the false positive result. You can't differentiate the inflammation post-procedure versus the vegetations. So in this scenario, the suggested way is to combine DOE and PET scan, whereby increase the sensitivity from about 40% if you perform with the combination tools, whereby combine DOE and PET scan increased about 50 to 67%. So of course, I think the real problem here will be how are we going to gain access to the PET scan? We know that the PET scan is not widely available in Malaysia. Not all hospital has got PET scan facility, and the turnaround time or the TCA is long. So, but I think it's good that to know that when do we need to consider for PET CT. Now, coming to the microbiological evidence, okay, gold standard is still blood culture, whereby the sensitivity about 50%. If patient able to go for surgery and you cultivate the valve for culture, the sensitivity is as good as the 25% only. But if the lab are able to perform 16S RNA directly on the explanted valvular tissue material, sensitivity is about 60 to 75%. As for culture negative IE, we still rely on our traditional or conventional method by telling our microbiology colleague to prolong the incubation period. We still heavily rely on serological test, okay? Or of course, if patient going for surgery, the valve tissue we can send for PCR and 16S RNA. Well, what is available in future? There's this thing called cell-free microbial DNA, okay, whereby it's helpful to detect the presence of the microorganism even when it's culture negative due to fastidious organism. As far as the 8 days, even patients already been exposed to antibiotic. So this is something that we are looking forward to. Now, this is an interesting question. Yeah? How many sets of blood cultures that we need in order to help us to diagnose infective endocarditis? So traditionally, we'll teach our housemen, our doctors that we need 3 sets, 30 minutes apart and from different sites. So the poor housemen have to book 3 times and also spending a lot of time in finding the veins. Okay, so this is a study comparing multiple samplings, okay, over single sampling 1 pair. Okay, 1 pair meaning that 1 aerobe and 1 anaerobe. So as a matter of fact, if you look at the diagnostic sensitivity, there's no difference. The p-value is not significant, whether you use multiple sampling versus single one-pair sampling. And in terms of optimal blood volume, statistically it's significant, meaning that the volume actually contribute a lot. Okay, if we take adequate volume, despite that you're only sending single sampling, one pair is as good as multiple sampling. As for nursing time, meaning that here probably our doctor is taking blood, then will be the doctor's patient's time. Definitely single sampling reduce the time spent onto the patients. And in terms of contamination rates, there's no difference, whether multiple sampling versus single sampling. So can we go for single sampling by using one pair rather than multiple punctures? So this is a guideline. This is taken from the IDSA, right? So they recommend 2 sets. Okay, why 2 sets? 2 sets meaning 4 bottles. The reason behind, if let's say your blood culture, you're able to isolate organism that typically associated with IE, for example, streptococcal atelectae, which is associated with the infective endocarditis. In this situation, 2 samples is enough to consider as a major criteria. However, on the other hand, another scenario, the organism that you isolated from the blood cultures is representing the organism that's not usually associated with IE. In this scenario, you require 3 or more blood cultures that will constitute the major criteria. Therefore, they recommend 4 bottles, meaning 2 pairs, to cover for this scenario whereby your IE is due to the organism that not usually associated with IE. Okay, the other guidelines still follow the traditional recommendation, 3 sets of blood culture drawn 30 minutes apart. So it's really, we have to think about it, what is practical for us at this situation whereby we have a shortage of manpower. Okay, and we can't ask our nurses to perform blood culture taking because that is not part of their procedures. So something that for us to ponder. Now, this is the last already. So this is the paper that, landmark paper that published in 2019 in New England Journal about the endocarditis converting from IV to oral randomized control trial, unblinded, to prove the non-inferiority. And in this study, mainly the IE is confined to the left-sided and caused by the gram-positive organism. And this study proved that it's safe or non-inferior to convert patients with IE due to the gram-positive organism to oral therapy after being given at least 10 days of intravenous therapy. So now this is the latest paper published in CID 2026, endo-oral, which is performed by the French group in 2 tertiary centers. Is a retrospective real-world scenario, whereby what's different here comparing the POET study. In POET study, they excluded patients that right-sided IE, valvular abscess, atypical pathogens, IVDU, and etc. But in this endo-oral study, they included POET eligible patients. And their findings are quite similar with POET, whereby IV to oral switch with a minimum of IV 10 days is safe in terms of the no difference in terms of failure rate. But as for the POET eligible patients, the proportions of patients' treatment failure was lower as compared to POET eligible patients, although the statistically is not significant. So this is very encouraging to say that if, let's say, infective endocarditis, left-sided, is due to the gram-positive organism and patient is relatively stable, after 10 days of IV antibiotic, then you may consider to switch to oral. But the only setback is that both study has not actually standardized the choice of oral therapy that they recommend or use. So they use different regime of oral regime, some combinations, some monotherapy. As for strep, they use amoxicillin mostly, but as for staphylococcus, they use various of a combination, including rifampicin, doxycycline, quinolone, and etc. So in this aspect, there's still room for study or research or investigation to find out if we want to switch from IV to oral after IV of 10 days of IV antibiotic, what would be the best oral therapy? So with that, I stop here. Thank you very much.
Thank you, Dr. Loh. Dr. Loh, the IV to oral switch for IE, it was recommended by both, is it? The
Yes,
European Heart
yes.
Society and also IDSA.
No, there's
IDSA,
only
do they?
one of it, not all.
Only the European
Yeah,
Society
and
can.
and it's only brief. They write it in a few sentences only. So I think they're probably a bit cautious when you're writing the guideline. They didn't even actually explain it in detail. Okay, the
Right.
detail actually is in this POET study as well as the endo-oral study.
And all the patient must have a TOE done, right, to exclude complicated IE.
Yeah.
Okay, okay. So are we ready to switch to oral in Malaysia for IE? What do you think, Dr. Loh?
I think we can start. We can try, but selectively on suitable patients. Then I think we should follow up closely, lah.
Yeah. I think I'm not sure whether we are revising our IE guidelines, national IE guidelines or not. Whether we are trying to adopt this
Do
IV to
we
oral
have an
switch.
IE guideline nationally?
Yeah, we have.
We have CPG, but it's quite long already, I think.
Yeah. I think it's
Right?
time to update.
Before COVID, I think.
Yeah, Dr. Suresh was part one of the panel, I think, if I'm not mistaken.
Leong Chi Lun, I think.
Leong Chi Lun as well, huh? All right.
Chi Lun is inside here?
Lim Chi Lun is here, but Leong Chi Lun, I'm not sure. No, I don't think he's here.
All right.
Yeah. Still a long way to go, I guess. We probably need the
But I
very
think
short.
we need the thing blood culture lah. You know, as you know, our manpower is short and things like that. I think it's good time that we do alter the practice. But I do not know how. Okay, who reads the CPG? Do they mention 3 sets and then separate time?
No, we are. I think for us, we usually practice 2 sets. 3 sets, I think, is a bit overdoing, I guess. And now culture bottles.
Actually, I do not know what's written in our Malaysian CPG, frankly speaking.
Anyone read?
I think it's probably 2 set good. They have a check. So now we stick with 2 sets or go for 1 set?
Ideally, it's 2 sets.
2 sets.
Okay, but then when you come to a scenario whereby you are very short of people or patients with venous access is difficult, maybe we can, certain scenario, we can accept 1 pair, provided the volume is adequate.
Yeah. I
And
still
you
think
probably have-
volume is
yeah.
I still think volume is most important in terms of
Correct. Yeah. Other than the technique of collecting the culture, the volume is definitely contributing factors.
Yeah. All right. Any more
Okay.
questions?
I have a quick check. In Malaysia, our CPG is 2017.
Okay.
Long already.
Before COVID.
So
Yeah.
they said that at least 3 sets of blood culture should be obtained at separate venipuncture sites before initiation of antibiotics.
Wow, 3 sets, huh?
3 sets, yeah, I remember it's 3.
So we have not been following our own guidelines.
It's time to revise our guideline.
Okay, never mind. We are 1 step ahead of the guidelines.
Okay.
Any other last questions from the audience? Last questions before we go to the last presentation by Dr. Alif. Alif, you can share your slides. Okay, if there's no question, we'll move to the last presentation. Alif, the floor is yours.
Hi, good afternoon, everyone. I'm being given the last slot for today. How much time do we have, Stephen?
15 minutes. I give you 15 minutes.
15 minutes. Okay. Okay. All right. So, this is from the UTI section for. I joined it virtually. So basically, it's from a section for UTI. There's 4 components in this. So, it consists of kidney transplant in UTI, bacteriuria and pregnancy, patients with stones and stents. There's a catchy phrase to it, rocks and hard places. And the final part is neurogenic bladder or SCI, spinal cord injury patients. I think these are all very relevant in our practice because these are very commonly referred scenarios in UTIs. So in kidney transplant, so I start off with kidney transplants section first. There's a paradigm shift nowadays whereby clinicians traditionally treated almost any sort of positive urine culture. Basically, it's UTI until proven otherwise for causes of graft rejection. So current evidence is treating ABUs or ASB beyond 1 to 2 months does not improve graft survival, but in fact, it actually increases the risk of ESBL producing E. coli or other MROs. And also, they have to also keep in check the drug-to-drug interaction with several immunosuppressants like your CNI, like triclolimus. So this was from actually this Swiss guy. So he's actually summarized this slide, basically saying that as far as 2005, there is no difference in terms of if you treat or not treat beyond 1 month, beyond 2 months, sorry, beyond 1 month to 2 months, there's no difference if you treat if it's asymptomatic bacteriuria. In terms of pyelonephritis, cystitis, or MDR colonization, graft function, all-cause mortality. But even having said that, many clinicians, especially those transplant nephrologists, they like to treat because it's easy to diagnose, and there's no other causes related to graft rejection or graft loss. So here in this slide, they mentioned that asymptomatic bacteriuria, there is role for treatment within 1 month, but beyond 1 month, there's not much role. In fact, they don't actually recommend screening after 2 months for IDSA and AAST, American Society of Transplantation. Some of them, as you can see, the right side of your slide is actually they screen almost every week. In fact, they do twice weekly even. So because they want to look for test of cure, So for IDSA, there's no recommendation of routine screening beyond 1 month post-transplant, and is insufficient evidence to inform recommendation for against or treatment of ASBs within first month. So basically saying that if it's more than 1 month, you shouldn't screen, and you shouldn't treat. So this IDSA guidelines is basically for non-kidney transplant. So basically, you're saying now we have complicated versus uncomplicated UTIs. So the IDSA has recommended 5 to 7 days of quinolones or 7 days of other effective antibiotic treatment, except men with prostatitis, suspicion or diagnosis. So if you look at the bottom there, AST in IDSA community of practice, simple cystitis, they go only 5 to 7 days, but if it's early post-transplant, especially those who have a donor who has UTI, so they will treat. The threshold to treat is very, very low. In fact, they will treat even though if you don't tell them to. Pyelonephritis with complicated UTIs will be treated 2 to 3 weeks, and treatment should be continued until adequate drainage of abscesses. So we find that some patients have perinephric collections of abscesses that requires drainage. So these are quite complicated cases where UTIs in kidney transplant patients, they have preoperative, intraoperative, and postoperative risk factors. So in patients like in Selayang, I would say almost all of them are actually dialysis patients who have a long waiting time in going for transplant. So which is why they are anuric. Almost all of them are anuric, and they have a bladder who is actually very small. So the bladder has actually forgotten how to produce urine. This is where it falls beyond in urinary tract abnormalities, or they can actually have a neurogenic bladder or vesico-ureteric reflux. So it's very, very difficult because some of them are subjected to prolonged stents. And they actually get 6 to 8 weeks sometimes of stent before the stent is being removed. So this is a recipe for recurrent UTIs for patients because the effect of biofilm. So intraoperatively, whether you got deceased donor, that carries a higher risk because most of our patients are deceased, cadaveric renal transplants, prolonged bladder catheterization. So here, in Selayang, they will get at least a week or sometimes up to 2 weeks of CBD. Because they want to make sure the urine outflow is good, patient doesn't have vesico-ureteric reflux and whatnot. Whereas in my experience in UK, they remove the CBD within few days, and in fact, the stent is being removed very fast, actually within a month. So the reason why here local practice they practice keeping the stents long is because of the bladder itself. They call it it's either a neurogenic bladder or or a small bladder. So post-operatively, everybody will get immunosuppressants, and depends on what kind of immunosuppression you get. If you get anti-thymocyte globulin, you're at higher risk of getting recurrent UTIs. Okay, so why are recurrent UTIs in kidney transplant? Because they have stents, and also they have dysfunctional bladder. But in our setting, I think the biggest problem is dysfunctional bladder, because they're so long on dialysis and the bladder is actually being atrophied, and promotes urinary stasis and incomplete voiding. Right. So how to avoid this? Now this is actually not a common guideline, not a common rule, but it's actually been written by the authors below in the infectious disease in North America, where they actually propose this pathway where those who have recurrent UTIs, however asymptomatic or symptomatic, they should get a post-void residual imaging to evaluate for prostatitis. And if there's structural abnormality present, they should correct it with surgery. If there's no structural abnormality, they should use voiding cystoscopy to determine whether it's VUR or not. If there is a VUR, consider surgery or endoscopic injection. So they have to rule out prostatitis, because these are common causes of urinary outflow problems. And so Halskov has actually tried to use this in 2023. So they have actually recruited 103 patients. Half of them, more than half of them is actually males, and had only a proportion of them got the urodynamic test. And there's only about less than a third having residual urine. So, but this is not widely approached, not widely practiced yet. But so hopefully we can actually implement this in future. But because we have a lot of patients waiting, whatnot, so we predict that there will be a lot of patients with structural abnormalities. So this talk also talks about antimicrobial approach. So I think also we should implement to patients and talk to them about fluid intake, simple things like wiping from front to back rather than back to front. Don't hold the urine, things like that. And also they've actually implemented during my observership in Manchester recently, they've actually already started using methenamine hippurate for their clinic patients for those who have recurrent UTIs, especially those who are recurrent asymptomatic bacteriuria. But the caveat is not to use patients with renal impairments, EGFR less than 30. And some even actually promote using cranberry juice. But the problem is cranberry juice, it interacts with your tacrolimus. So that's another factor to promote to consider. So in terms of secondary prophylaxis, they don't really implement much for continuous or monthly cycling and also versus postcoital in women. So immunosuppressants. So now the immunocompatibility in terms of so we know that kidney transplant has a higher immunological risk as compared to other solid organ transplants like liver and lung. So if you have a high incompatibility, they are more at risk of UTI. So this indirectly expose you to immunosuppressants and actually higher infection risk. So we still have a long way to go. A lot of questions remain. Who to treat, who to screen, so basically we need to find out why. But for us in a local setting, we know that these patients have a long waiting list, and they are all dialysis dependent patients as compared to one in the first world country like in the UK, where they get their transplant early when they're still passing urine, so they don't have much obstruction or any bladder issues before. So optimal treatment duration is still a question. Whether is it treatment longer? Does longer mean better? So this is another cohort of patients need to talk about. We should stop testing for to look for tests of cure. In the UK, they are actually very strict diagnostic stewardship. So the diagnosis stewardship are actually driven by clinical microbiologists. So you'll have to have a very good reason to actually send for urine culture screening in a post-op patient. So patient selection for diagnostic workup for recurrent UTIs and optimal management of recurrent UTIs. I think we should also imply on antimicrobial approach. So the second section is pregnancy and bacteriuria, hot topics of the day. So this is delivered by Professor Barbara in Washington U. So basically, what was discussed in that talk was ASB or it's not Amanah Saham Bumi Putra. It's actually asymptomatic bacteriuria. And UTI are a common entity. They overlap each other, even they precede each other, or sometimes vice versa. Right? So they have a negative impact on pregnancy if it's not treated. So die if you don't, what would they say? What die if you don't, you still die lah. So so anyway, you still have to treat asymptomatic bacteria. This is one of those indications in the guidelines where two of the most important factors to treat in asymptomatic bacteria. One of them is pregnancy, another one is urological procedures breaching mucosa. So causative organisms are pretty much the same, and treatment also is the same as well. So a lot of questions raised. Since this is all running in our mind at the moment, even the appropriate colony count also tak boleh pakai in terms of diagnose ASB and UTI, because even some UTI, active UTI, if it's asymptomatic, also colony count is actually lower than those who are asymptomatic. So how to get a good threshold of colony count to decide our clinical management, right? What makes the difference between ASB and UTI? So the guidelines that actually she showed three here by sequence of years, it's not really, is weak recommendation, you know. So basically saying that in first trimester in Canada with urine culture who are asymptomatic, it applies to pregnant women who are not experiencing basically or asymptomatic and are not at increased risk of asymptomatic bacteriuria. Whereas the EAU for this year, there is a caveat there. Screen for and treat ASB during pregnancy, but the quality of evidence is low. And at the end of that, they say consult guys. So this is a forest plot. In
Sorry, Alif, you're muted.
Can you hear me now? Can?
Yeah, can.
Okay. So this forest plot shows all of it is actually for treating asymptomatic bacteria and symptomatic UTI in pregnant women. So even though the studies are old, but actually they still hold strong and true until now. So this is about the threshold for whether it's significant or not. So this, as I mentioned just now, even with a colony count of 100,000 or 10 to the power of 5, actually is applicable mostly initially. Traditionally, it was actually to increase the specificity of voided urine versus catheterized specimen. So sometimes a patient who has more risk, they can actually have lesser colony forming units in their urine culture, right? So current thresholds, if we hold on to this rule, we may actually miss a true infection in pregnant women. So we shouldn't be using a hard and fast rule on how many colony forming units to start treatment. So this shows that in a patient with recurrent UTI, the outcome is still UTI in pregnancy. Someone who has ABU or ASB around 20 weeks, they still get UTI during pregnancy. UTI in pregnancy can also predict preterm birth, which eventually leads to endometritis, and also preterm babies, which results in mastitis. So all in all, they are all related. And they are all actually low-risk pregnant women. So Professor Barbara also did this slide basically saying that pyuria, regardless of anything across this spectrum of slides, does not predict subclinical UTI or UTI, even ABUs, or even there's no urine, there's no bacteria. So it doesn't mean that pyuria is actually UTI, right? So the only reliable thing is actually urinary symptoms. Even presence of bacteria also does not reflect UTI. So what's the duration? So up-to-date EAU and ACOG has generally up-to-date and ACOG pretty much the same. ASV 5 to 7 days, lesser is better, or a single dose of phosphomycin. And pyelonephritis is at least 14 days. The problem is when you have a gravid uterus and they are actually at risk of hydronephrosis and whatnot, this can actually stretch longer. So it's a case-to-case basis actually. This is also a valid point that was raised, urine collection during pregnancy. So she actually mentioned that those who are pregnant and morbidly obese, you are subjected to more risk of contamination. So she gave an example. Imagine an obese lady going to the toilet, spreading the legs and then trying to get a good sample of urine. End up will get very high contamination rate. So instead of asking them to go to the toilet, reconsider contaminated samples and probably use a CBD in out, which can be quite uncomfortable lah. All right. So do we need risk factor based guidelines? Well, it varies by country. You can see here South America and Europe, there's much of difference in their spectrum in terms of ASB, UTI, and PILO. Maybe it's because of their lifestyle and whatnot. And some cultures, they're not keen for antimicrobial approach. So sometimes it may differ. And also access to adequate prenatal care varies. So here was a nice paper which was highlighted to use a risk factor guided approach. But the thing is, when you're pregnant, you're already considered a risk factor, kan? So whether you should use a selective or non-selective asymptomatic bacterial screening, and the role of actually repeating the culture if it's considered contaminated, right? So again, a lot of work needs to be done. Individual's approach, not every pregnant woman is the same. So always consider the contamination issue as also the colonizing forming unit. Colony forming unit is actually there's no particular threshold to say whether this is a significant UTI or a true asymptomatic bacteriuria. Okay, next one is the stones and stents. Sorry, Stephen, do I still have time?
Can go ahead.
Okay. So this is actually delivered by this Dr. Lawrence Leitner. He's actually a Swiss urologist. He's not an ID physician. He's not a microbiologist. He's a urologist talking about the mechanisms of those who are patients with stones and stents. So we know that bacteria causes biofilm matrix when we have a plastic or any side of foreign body in the urinary tract. And the more that we treat, they will induce antimicrobial resistance. And the definitive solution is not antibiotics because there's poor penetration within these plastic structures, but actually to remove or to replace the stent. So he has a very good case that he shared. So I'm sharing here. Someone who has a double J stent. So for those who doesn't know how a J stent, why is it called J stent? Because you see on the kidney there and the bladder there, those are J-shaped stents. So these are actually hooked within the bladder and also the kidney. So this patient, she mentioned irritative symptoms only, afebrile, CRP normal. So he asked the floor what was the treatment, but I don't know what the answer was by the audience. But basically saying that in a patient who has stents, you should minimize the dwell time. So the shorter is the better. So short term is actually 2 to 6 weeks, but sometimes you need to dwell longer. For whom? These kind of patients where patients have cancer, things like that, which are actually causing obstruction, until the cancer is being removed or being treated. So sometimes they can last more than 6 weeks, but usually it rarely lasts more than 12 months. And he did mention that there's no such thing of antibiotics to sterilize a colonal stent, only removal can. This is actually a good source control approach. The materials are usually polyurethane or silicone polymer. So this is a very important slide because we tend to diagnose UTI based on symptoms like on the left side, urgency, frequency, any hematuria, but actually it's because of the stent itself. You will have some interference in terms of work, sleep, even sex even. And you will expect some leukocyturia when you send for urine FME because this is actually how the body reacts by when you have a foreign body inside. So what is it defined as true UTI is based on your systemic signs, fever, flank pain, rising CRP, procalcitonin, white cell count raise, clinical deterioration, or concomitant bacteriuria, right? So sometimes, most of the time, irritative symptoms plus positive culture doesn't always equal UTI. So always consider these other symptoms on the right side. Oops. Okay. So JJ stents colonization doesn't equal infection. So because about a fifth of them develop bacteriuria and only a proportion of them progress to urosepsis. And you should expect the stents to be colonized. It's normal. But the longer you treat the stent, by more than 6 weeks, 100% of them will be colonized. So the ABU antibiotic treatment of bacteria, asymptomatic bacteria, is you don't aim to sterilize the biofilm and because it may select resistant organism. So the latest EU guidelines recommend against asymptomatic bacteria for patients with stents. But this is actually not going for urological procedure. This is actually basically those with symptoms like the irritation symptom that I mentioned to you just now. So who are those potential who become septic? So the longer you keep the stent, actually they eventually can become septic. So dwell time of more than 2 months, that's the only risk factor you can get predict bacteriuria and urosepsis. So again, you should actually talk to your friendly urologist how long they want to keep the stent. But I understand, with our scenario where our Malaysian healthcare system is, there's a lot of limitations here and there, that could be an issue lah. But we should always convince them. So what do the guidelines say for IDSA and EAU? Strong recommendation, we shouldn't treat catheter-assisted ABUs. All right, and replace and remove the device before starting antibiotics. We shouldn't be screening and treating ABU before mucosa breaching injury. Give them stat dose of antibiotic before. I noticed there are some practices, I'm not sure which other centers, but including my center, they aim for test of cure. It means they send urine culture before patient gets admit the patient, sterilize the urine, and go for the procedure, which is, I think, not the right thing to do because our guidelines, even the EAU co-written by the urologist, didn't say. Right? So we shouldn't screen and treat for test of cure. So treat the patient, not the culture. In a stented patient with ABU and no systemic signs, no antibiotic, no stent exchange, and minimize dwell time. So second patient, I think I'll just go fast. Basically, she has a JJ stent for cancer. This is what I mentioned just now, the scenario where the stent will be there for longer, more than 6 weeks. Imaging got hydronephrosis. So the approach, is it antimicrobial, change the stent, or manage it by continuing antibiotics only. So the result was basically the patient had urgent PCN, percutaneous nephrostomy, as compared to JJ stent. Blood culture grew pan-susceptible E. coli. And this scenario is where Dr. Lautner mentioned that the importance of sending the JJ stent for culture, right? So because that could be representing the whole infection, but patient clinically responded to augmentin and was discharged fast because early source control. So drainage saves lives. Across all 4 papers, they have obstructive pyonephrosis, and the drainage was not delayed, no, because if there is a drainage delay, then it will actually increase mortality. So what to do with the patient with septic patient with a JJ stent? Antibiotics is the way to go, plus urine cultures and blood culture, fluid resus imaging. If there is obstruction, urgent drainage with percutaneous nephrostomy, and send stent for culture when removed. This is where treat obstruction fast, not the stent. But this is a very big this will be an issue because sometimes got no OT time, things like that. So, end up patient get, prolonged antibiotics and just supportive care, which is not the way to move forward lah. So urine culture sometimes can be misleading. So he suggested ask the surgeon to send a JJ stent culture because it tells more truth than the urine, right? Okay, so this slide basically summarizes everything. Asymptomatic bacteria, don't treat. No need to stent exchange. Just antimicrobial free approach. Stent related symptoms, no. The only time you actually treat and change the stent is when patient has urosepsis obstruction. When the patient has long dwell time, you need to do stent exchange. But if it's just where asymptomatic bacteria, you shouldn't give antibiotics. JJ stent malfunction only if symptomatic, like fever that I mentioned to you just now, as compared to the irritative symptoms. And with recurrent febrile UTIs, yes, definitely, yes, have to send blood, urine, and also don't forget your stent culture by asking your urologist to send. So I think for the interest of time, I won't be talking about all of this. So basically, this outcome rule, and the first one is actually ABU in a stented patient, no antibiotic, no stent exchange, treat the patient, right? You must be confident, ask the patient, any fevers in the checklist is now, do they have such symptoms or not? With the JJ stent, drain the obstruction and not remove the stent, because if you cut out the stent, if it's just fully inserted, then it be more problem. So antibiotics within an hour, drainage, they did fast, and they do a JJ stent exchange if needed. And stones, okay, so I think I wanted to mention this. Stone is actually a true source of infection. So sometimes stone is the infection. Okay. Interest of time. Sorry, last one. I promise. Neurogenic bladder and spinal cord injury. So for this case, we also get cases where patients don't have symptoms of UTI because they cannot feel it. And they are all subjective for antibiotics based on their culture results. And because of pyuria. So this French speaker mentioned about the relevance of pyuria. So in these scenarios, we shouldn't be relying on pyuria to equate them as UTI. So new EAU definition of localized versus systemic symptoms should guide your treatment choice. It's already what time? 1:45. Steven, you want to go?
Maybe you can do the landing.
Okay. So last one, last slide. I promise Apple. Ping already texting me. So this one, spinal cord injury. So management of UTI in neurogenic bladder patients, avoid continuous use of long-term antibiotics. Sometimes there is such thing called WOCA, weekly oral cycling of antibiotic prophylaxis, provided long-term positive results. But this is actually something to look at, because this is still something to, even though it's a strong recommendation, but it needs to be approached properly. Okay, because this was based on these two papers. So what they did was weekly sequential antibiotic prophylaxis for recurrent UTIs among patients with neurogenic bladder. They actually subjected patients for antibiotics. And they say there's no MDRO emergence, despite the incidence of antimicrobial resistance of isolates from urine culture between two groups was not different during follow-up period. So they follow up these two patients, those who are treated and not treated with weekly sequential antibiotic prophylaxis, and they didn't see any MDRO emergence. And they so this is apparently the outcomes for cystitis and febrile UTI is actually quite significant if they use WOCA. So this is something new, but I think needs a proper approach in the future. So in conclusion, needs a multidisciplinary care. Neurogenic bladder is heterogeneous. Prevention is always better than cure, and we should have practice stewardship and education for after risk factor optimization, and consider non-antibiotic approach for recurrent UTI. Thank you. Okay.
Thank you, Alif.
Sorry.
No worry. I think UTI is such an important topic, and it's such a shame that we don't have more time for you to cover all the aspects that you want to present to us. But anyway, this is a recorded sessions. We'll be sharing the recorded videos through emails, and also we put it on the websites. I think the speakers have no problem sharing the slides. I'll get from them and then email to you all as well. Any last questions before we conclude?
Alif, Dr. Chow here.
Yes,
So the
Dato'.
conclusion of asymptomatic bacteriuria in pregnancy, I know the conclusion is yes, right? You need to screen and treat the ABU, right? Do they mention about follow-up urine culture again and again?
No, Dato', it wasn't mentioned.
So one time only lah.
It was mentioned only about when to screen, how to screen, and when to treat. But it didn't say about follow-up urine cultures. Yes.
Because what KK most of the time they do is they push and push and they screen and screen, and then until ESBL, then they will refer to hospital.
Yeah. Unfortunately, that's the because they want to look at test of cure lah. They want urine to be quick, clean. She didn't touch on that, Dato'. Unfortunately.
All right.
But the approach for other things lah, like non-antimicrobial approach, you know. But the thing is, the dilemma lah if you don't screen and if you don't treat, so basically ASB is equals to UTI until proven otherwise. But how frequent to screen and treat too, she didn't touch on that.
Alif, you mentioned the one of the choice of antibiotics they use for ASB in pregnancy is oral fosfomycin. Is it one of the options that
Yes,
they use?
single dose oral fosfomycin, correct. That's based on IDSA and also I think the EAU. Single dose.
IDSA and EAU lah, right? And it's for any of all the sensitive organisms, right? E. coli and all the urinary tract infections. All right.
Sorry, up to date and ACOG, my mistake. And also EAU, up to date and ACOG. Sorry, I just share my slide here. Up to date and ACOG, basically they are the same, but the EAU promotes a shorter course of antimicrobial oral option.
Right. I mean, I'm not sure about others, but I think in my practice, I usually reserve oral fosfomycin for patients with ESBL, with asymptomatic bacteria with ESBL, E. coli. But it seems like it's a recommended first line therapy for in other guidelines as well. Yeah, but I usually reserve it for oral fosfomycin for ESBL. Yeah, because I want to avoid inpatient IV meropenem or ertapenem. All right, any other last questions?
But sometimes I feel that some pregnant women, we have a low threshold to do an ultrasound, kan? Because especially those who have recurrent UTIs, we want to make sure, because we cannot escape the fact that they may have actually hydronephrosis because of the gravid uterus. So that's one thing that Professor Barbara was highlighting also. They memang at risk, especially if they have a very gravid uterus or they have a twin pregnancy or whatnot.
Yeah. All right. Cool. I think everyone would agree that we have a very productive and very engaging sessions today. So we'll consider to have a second sessions for this echo training from ESCMID, because we still have a few other members that have participated in the conference. If there's nothing else, we probably can conclude today's sessions. Thank you very much. Thank you to the speakers, Dr. Chow, Dr. Loh, and Dr. Alif. Fantastic presentation. We'll share the slides to you all later. Bye.
Thank you.
Bye.
Thank you. Bye-bye.
Welcome to this special CME. So usually every month we have this CME slot for the ID trainees, continuous teaching. So this slots has been specially given to MyICID to organize this echo training from ESCMID conference.